Welcome to part 3 of pain. We're going to discuss pain management in general. You're going to have 2 other PowerPoints that are going to go more in depth into different treatments like medications and alternative therapies. I wanted to start out this PowerPoint discussing some basics about pain management. And as your career starts getting longer and longer, it's very easy for us to forget the basics of nursing care, and pain management is a really easy thing to forget. The first is all patients have the right to appropriate assessment and management of pain. We also need to remember that pain is always subjective. It is what the patient says it is. We also have to remember that physiological and behavioral signs of pain are not reliable or specific for pain. There can be pain without any of these present. Pain is an unpleasant sensory and emotional experience. Nobody wants to be in pain. Assessment approaches, including tools, must be appropriate for the patient population. We're not going to ask people who can't talk to tell us their pain score out of 0 to 10. We need to remember that pain can exist even when no physical cause can be found. We need to remember that different patients experience different levels of pain, their responses even to comparable stimuli. No two people are the same, and their pain responses won't be the same either. This one's important. Patients with chronic pain may be more sensitive to pain and to other stimuli. Their body is always in fight or flight mode because of the chronic pain. And lastly, unrelieved pain does have adverse consequences. Acute pain that is not adequately controlled can result in physiological changes that increases the risk of developing chronic pain, severe complications, and even death. Before we can talk about managing pain, we need to discuss some major issues we have with managing pain. And sadly, these issues become barriers to treating and caring for our patients who are in pain. The first issue we have with pain management that causes a barrier to care is physical dependence. Physical dependence is a state of adaptation that is manifested by a drug class-specific withdrawal syndrome that's produced by abrupt cessation, rapid dose deduction, decreasing blood levels of that drug, and/or administration of an antagonist of that drug. Physical dependence does not imply addiction, but rather it's a state where the body is dependent upon the medications to function, and without the medications, the body is going to go through withdrawal. And this dependence usually occurs after 1 to 2 weeks of regular use, but can sometimes happen sooner. The second issue we have is drug tolerance. This is different than dependence. Drug tolerance is a state of adaptation in which drug exposure to a drug induces changes that results in decreased effects of the drug over time. Tolerance is the diminishing effect of one or more of the drug's effects resulting from repeated use over time. The person needs more and more of the drug in their system to get the same effects from the medications. This doesn't only happen with pain medications. We see this with diabetic medications, cholesterol medications, and drug tolerance does not imply that they are addicted. Even though both of these issues do not mean addiction to medication, they're often treated as if the patient is addicted. They get labeled, they get undertreated with their medications, and they get treated poorly by healthcare providers. Unlike dependence and tolerance, addiction has a neurobiological component. It is actually a neurobiological disease. It's psychological. It has genetic, psychosocial, and environmental factors that influence it. And addiction to pain medication rarely occurs in people who are taking the pain medication for real physical pain. You see these addictions to emotional pain. People who become addicted to pain medications will have addictive behaviors, and these addictive behaviors can include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving the medication. The harm could be negative, social, and legal consequences, and they will still become obsessed about getting the meds. They'll appear frequently intoxicated, and they'll start missing social and occupational events because of medications in their system, and they don't care that it has bad consequences. An addiction occurs over a long time. Addiction's not going to be the result of one hospital stay or for treatment of one episode of acute pain. There's another barrier called pseudo-addiction. This occurs in people whose pain management is inadequate, and they will do anything they can to get their pain relieved. The difference with this is that the addictive-like behavior stops when their pain is controlled, because these people are truly in pain and they're doing anything they can to get it controlled. Their behaviors can include anger and hostility and, quote, drug seeking because their pain's not being controlled. And unfortunately, these people get avoided and they get labeled by healthcare workers, which then makes their pain management worse, which means they're going to continue with these pseudo-addictive behaviors until someone finally listens to them. Patients and healthcare providers often do not understand the differences between physical dependent, addiction, and drug tolerance. And because of this, healthcare providers fear problems with addiction, and they're going to alter the way that they use and prescribe the pain medication. And this causes so many people who are actually in pain to not get the pain relief they need and deserve. The danger of addiction to pain medication is vastly overrated. Although available data on addiction consistently shows that it's rarely a result of using opioids for pain relief, healthcare professionals still have exaggerated fears. Patients and families also have fears related to addiction. If we can carefully explain the differences between physical dependence and addiction whenever the patient starts on opioid medications, that's going to really help our patients and their families. And it's crucial that nurses and other healthcare professionals not label a patient as an addict or a clock watcher or a drug seeker, because these labels have started causing biases and negative impacts on that nurse-patient relationship and has really changed how we as a society treat people in pain. Now that we've discussed barriers to pain management, let's talk about it and what our goals are. First, we want to remove or alter the cause of the pain. This means so many different things depending on the cause of the pain. If the pain is from a broken bone, we need to fix the broken bone. If the pain is from a stab wound, we need to fix the stab wound. And can we as nurses do some of those things on our own? No. And because of that, pain management really is a collaborative effort. We alone cannot do all of the treatments needed to relieve pain, so we need an interdisciplinary team to help us. And we need to know that pain relief should be evidence-based and comprehensive, which means we're doing several things to help the pain and not just giving medications. When we treat pain, we need to work on one or more of the processes in the pain process to close the gates of pain. So to help transduction of pain, we need to do things that cause the blockage of the release of the chemicals that are starting the pain process. This could be things like NSAIDs or steroids, which are going to release the chemicals such as prostaglandins. We can use local anesthetics and anti-seizure drugs to block the sodium channels that are going to inhibit the production of nerve impulses. To help block transmission to the spinal cord, we need to do things that will stop processing in the nerves and brains. So this could be local anesthetics, this could be TENS units, this could be massage. We can block processing and transmission to the brain with opioids. And we can do things to alter the perception of pain. Perception altering works wonders because there are many different sites in the brain that perceive pain. We can alter and reduce pain with distraction and relaxation. We can use opioids, tricyclic antidepressants, anti-seizure medications, and all of those things are going to decrease how a person perceives their pain. To affect the modulation process of pain, we need to remember that the body needs the pain in some instances to protect itself. We don't give pain medications to someone with a broken bone without splinting the bone first, because if the pain is gone, they're going to use that bone again and injure themselves even more. When we do want to affect the modulation of pain, we want to increase endorphins, or those happy chemicals. This is where complementary and alternative therapies come in handy, like pet therapy, massage, and humor therapy. They make us happy, and that releases endorphins that can decrease the pain. We can give tricyclic antidepressants and SNRIs to manage chronic pain and cancer pain by interfering with the reuptake of serotonin and norepinephrine, which would make it more available to inhibit those noxious or annoying stimuli and lessen the pain. We can also use mental conditioning to help lessen the pain, like what happens with athletes and soldiers. They learn how to talk themselves over the pain, like that phrase, mind over matter. They're using the brain to overcome the pain with controlled breathing and guided imagery and even like self-hypnosis. So we've already discussed how to assess pain, but there's a few more things that we need to be mindful of when it comes to assessing pain and setting goals for pain management. First, we need to establish that trusting nurse-patient relationship. Things like labeling patients as drug seekers, eye rolling when they ask for pain medication, and not believing the patient when they say they have pain doesn't allow us to form that trusting relationship. If we don't have the trust of our patients, nothing we do will matter. We won't do enough, we won't care enough, and we won't keep them satisfied with their treatment. We also need to go into our assessment and goal settings knowing that we have an ethical and legal responsibility to relieve their pain. When we set goals for pain relief, we need to make sure that they're smart. If someone has chronic pain and a pain goal of 0 may never be achievable, why are we going to make a goal of 0? If someone was just in a major car accident and they have many broken bones, a pain score of 2 or 3 may not be realistic for that person. In addition to giving pain medication as ordered, there are many things we can do as nurses. I'm going to talk in general about these, as the next 2 PowerPoints will get more in depth into the specific things we can do. As nurses, we want to do things that will affect the pain experience. This may mean we apply a splint to a broken bone, or apply ice pack, or even use distraction or massage to help the person's pain. Sometimes something as simple as repositioning and reducing the noise in the room will help alleviate pain. These are types of complementary health approaches that are incredibly beneficial in pain management. If the pain is caused by emotions or is made worse with emotions and anxiety, we can do things to help the emotions and the anxiety, like music, explaining pain and treatments we may do that may cause pain. We also need to make sure we start and coordinate the pain relief methods we're doing. This means we should anticipate and prevent pain instead of waiting for the pain to get out of control. If we need to ambulate our patient and we know it's going to cause pain, medicate them for pain before we ambulate them. If we're going to do a painful dressing change, make sure we medicate them before and maybe even during or after the dressing change to alleviate their pain. We also need to try different pain relieving measures, not just pain medications. And of course, we need to evaluate the effectiveness of the interventions we do. This is an important step in the nursing process that we just don't do. If something we did didn't help the pain, don't keep trying to do it. If the medication didn't work as well as we hoped, maybe we need to speak with the provider to try something else. Part of this evaluation of our interventions is advocating for our patients. If something didn't work, we try to get something else that may work better or try other interventions that may help the medications work better. Treating pain is very different for acute and for chronic pain. For acute pain, we look more towards short-term, fast-acting medications that get the patient out of pain quickly. This is where you're going to see most of the opioids and opiates, also called narcotics, being used for moderate to severe pain. Medication like morphine, hydromorphone, fentanyl, oxycodone. Remember, most people will not get addicted to narcotics if they're having true acute pain. And also, treating acute pain adequately may help prevent chronic pain. For mild pain, medications like NSAIDs, those non-steroidal anti-inflammatory drugs, and acetaminophen are used. Remember, our goal is to provide optimal pain relief while minimizing complications from the pain and the medications. When we treat acute pain, giving pain medications around the clock is the best way to control the pain, and the next 2 slides are going to show you why that works best. This slide shows what happens when we only treat pain PRN or as needed. When we give a PRN medication when the patient is having high levels of pain, it will get absorbed in their system, then it reaches their peak effect. When pain medications like narcotics reach their peak effect, that's when the patient is at highest risk of major complications of narcotics, which is respiratory depression and sleepiness. This is that top red box. Then the pain medication starts to wear off and the pain starts to come back. Then we treat them again with the medications, which is going to cause a peak in the drugs to occur again, putting that person at risk of those complications again. And we do this over and over again, causing moments in time where the pain is relieved, but they keep having highs and lows with their pain. They don't get a constant, steady state of pain relief. It becomes a roller coaster of pain relief, each time setting the patient up for complications. Patients whose pain is treated like this will say their pain isn't well controlled because it keeps coming back. The pain doesn't stay away. They don't have long periods of time without the pain like everybody wants. Now let's look at this type of pain relief. When we treat pain around the clock, we keep a steady state of drug levels in the body so the person doesn't have the highs and lows in their pain. They don't get a big dose of pain medication when their pain levels are high, so they don't have the same risks of respiratory depression and drowsiness like the PRN dosing has. We're able to use a smaller amount of pain medication and we keep their pain at a more steady level instead of that roller coasting effect that we have with PRN dosing. The best way to achieve pain relief like this is to anticipate and prevent pain rather than waiting to treat pain when it gets out of control. We should be giving pain medication when the patient complains of pain levels 3 to 5 and not waiting until the pain reaches a 7, 8, 9, or 10. If we treat them at lower levels, we can keep them from having those high pain levels and they won't require the higher dosages of pain medications. We can use other pain relieving treatments, not just medications, when their pain is 3 to 5. We also achieve this by assessing our patients and evaluating our interventions. I promise you it takes more time out of our day to treat pain at a 7 to 10 level than to just bring in pain medications or doing other therapies when their pain is a 3 to 5. And just as an FYI, pain medications are ordered a certain way, and they're usually ordered PRN with a pain number scale associated with it. We must still follow those orders, even if we treat pain this way. We do not give the morphine that's ordered for pain level 7 to 10 if their pain level is a 3. We're going to use the medications we have ordered for the number that the patient is rating their pain at. So we have to make sure we always follow the orders we have, regardless if we treat our pain this way. Treating chronic or cancer pain is going to be very different from acute pain. These types of pain don't go away, and we can't just give some medications and have the person become pain-free. So these patients don't respond well to PRN dosing. Usually, these patients have their pain medications scheduled around the clock and not PRN. They may have different types of pain medications ordered than what we're normally used to seeing. They may be on combinations of medications to achieve the same pain relief somebody with acute pain would never need. We typically treat chronic pain with oral medications, and we may use IV medications if they have breakthrough pain or if they have acute on chronic pain. Breakthrough pain is when the chronic pain person has pain that's not being controlled by their normal medications. We see this when maybe their disease is progressing or something has changed in their body and they're not getting the same level of relief. Acute on chronic pain occurs when somebody with chronic pain has something acute happen, like surgery or an injury, and now they have acute pain in addition to their chronic pain. Our goal is to always achieve the maximum pain relief benefits with the least amount of side effects we can. And this can be very hard in people with chronic pain because the pain never goes away. This is where those alternative therapies become very important, and we're going to discuss those in another PowerPoint. Managing pain in the older adult is complicated. Not only can they have communication difficulties with hearing loss, vision loss, and maybe even speaking issues that can make assessing pain difficult, those can also cause difficulties when it comes to them safely taking the medication when they go home. Older adults may also deny pain, setting them up for complications of not treating the pain effectively. They may deny the pain for many reasons, so it's up to us to do our best to assess and educate the older adult about pain. In addition to these issues, the older adult's body may process pain medications differently, and they're at risk for responses to pain medication that are not what we expect. They may have stronger effects from the pain medication, which may make them more sedated and less responsive than we expect. They also have kidneys and livers that do not filter and excrete the medications as effectively, so there's a higher potential for drug toxicity, even at lower doses. It's recommended that providers start at a lower dose and titrate up on the pain medications much slower than they would for younger patients to help prevent these dangerous complications. There's a lot of education related to pain management. We need to educate them on the cause of their pain, sometimes even educating them about the gate theory. We need to educate the person on things to do and what not to do that can make their pain worse, especially if it's related to surgery or an injury. We need to educate the normal progression of the pain and how it should improve over time and not get worse. We need to educate on the medications and interventions we provide to alleviate the pain. And then we need to think about how and what we should educate them on if they refuse pain medications. Many times people refuse pain medications because they don't understand pain, the medications, or they're scared they're going to get addicted because that's what the news says. We may have to educate them on the complications that could occur if the pain isn't treated. If we're sending home pain medications, then we need to educate the patient on all of that. If they're going home on pain management, they need to know how to take the meds, any potential side effects, how and who to go to for refills of prescriptions if they need a refill, and what things they need to watch out for. I personally believe that nurses don't do a great job of educating on pain medications, and we see a lot of people coming back for more treatment due to the side effects and the complications from the medications at home. We should be educating our patients about pain every time we assess and treat their pain, and hopefully that repetitive education will stick in their brains so when they go home, maybe they won't have as many complications. The last thing we need to do when we are treating pain is to evaluate how effective our interventions are. This requires us to reassess the patient's pain, and the time frame for reassessment will be dependent upon what interventions we did. We also need to evaluate if the patient is making progress towards their goals and outcomes, like returning to previous level of functioning, ambulating, completing their ADLs, or whatever else has been affected by the person's pain. Remember that relieving pain isn't the only outcome we're focused on. We want them to go back to life as it was before the pain started. And this is the end of pain management.